Good afternoon, everyone. Thank you for joining us for the Medical Board of California Interested Parties meeting on prescribing guidelines. Pursuant to SB 189, this meeting is being conducted via WebEx. Public comments will be heard during agenda item 4 for individuals wishing to do so. In order to be ready for public comment, we ask you please ensure your comments can be heard clearly by connecting to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application and then select Switch Audio. You'll see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, this will still allow you to participate and hear the audio of the board meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, Dr. Thorpe. You can now start the meeting.
Thank you. Thank you, Sean, and welcome everyone to the Medical Board Opioid Task Force Interested Party meeting. We are actually very grateful to the work that's been done and compiling the multiple inputs we've had over the last several months. And in our effort to try to really create a document and an atmosphere really where California prescribing doctors can feel comfortable and confident in their when they do decide that opioid prescribing is appropriate for their patients, and not feel like every time they do that they're going to be sought out for discipline by the medical board. We certainly don't want that environment to be present, even though we recognize that there are significant barriers even currently to prescribing opioids, and that this opioid task force has been put together with the idea of trying to improve that environment both for patients and for practicing physicians. I want to thank the administrative leadership of the medical board, Bill and Reggie and Carrie, for their concern and their interest in this, and for seeing this through, and for Susan, Katie, and Letitia Robinson in their staffing of this process. It's been a quite a large compilation of resources, and looking at the volume, or at the level of the input that we've had over the last several months, we've actually been very heartened by that. There's been really very high quality input from our specialty experts in various areas of specialty, and also by interested parties that are patients and that are prescribing or prescribing physicians as well. So thanks to all of you for this document, this product, and this process that we are able to put into play, hopefully by 2023. We really couldn't have done it without all of the folks around the table, and especially those of you who are in the interested party community, and we are very grateful for your input. I've been very heartened by the quality of input that we've received. So without further ado, I will move to item. We have, really have 4 items on the agenda. Those of you who don't have an agenda in front of you, the second item will be just kind of what the process has been to update the guidelines since our last meeting, and what it would be after this current meeting. And those will be that commentary will be given by Mr. William Persifka, and then he will also help kind of digest the overview of the comments that have been received in item 3. And then item 4, which is really kind of mostly what we want to have the meeting about today, is further discussion of the current version of the draft guidelines. So without further ado, Bill, if you would be willing to move us through item number 2 and 3, well, then we will proceed.
Okay, Dr. Thorpe, thank you very much, and thank you for your leadership on this project. In terms of the process, well, it's been a very robust and very large process to update the guidelines, which were issued in 2014. There's a lot that has happened since that time, and we had to look at developments both in the state, national developments as well. There were lots of other guidelines and revisions that have been issued. Lots of learning took place. We couldn't have done anything without all of our subject matter experts. But we have now brought the guidelines to a certain point, and this we anticipate to be the last interested parties meeting. The previous interested parties meeting we found to be extremely helpful. We found many of the comments to be very learned, to be very passionate, and to give us your collective experiences in order to make these guidelines as effective as possible, always driving to meet the needs of patients. We were conscious that previous guidelines could be seen as restricting access to care. And so that was absolutely a priority. In this most recent guidelines, we have attempted to focus on encouraging physicians to use their best clinical judgment in treating patients and to provide the individualized patient care based on the unique characteristics and challenges that patient faces. And particularly in the most recent guidelines, we have made a few careful edits to the previous draft and focus in on really a handful of areas. Uh, the morphine milligram equivalent section has been amended to remove references to dosages that could be misinterpreted as prescribing limitations. In addition, both the initiating opioid trials and ongoing patient assessment sections have been modified to remove specific timeframes to follow up with the patient. Urine drug testing recommendations were edited to make them as clear as possible and to recognize that they are a very important component in terms of treatment. And the tapering and discontinuing opioid section was rewritten to focus on tapering strategies rather than discontinuing opioids. At all time, we have tried to be very aware and cognizant of the need to allow physicians to exercise their clinical judgment. We have been prudent in terms of making specific directions, being careful of using words such as may, should, and must in the guidelines. And we are very grateful for all the comments that we have received, and we look forward to receiving further comments. In terms of an overview of the written comments received, again, we are very grateful for the written comments that have already been received in this, the most recent consultation period. Public input on the updated guidelines was solicited this time to identify issues which could unintentionally impact either a patient's access or a physician's ability to provide appropriate medical treatment. Many of the comments related to the same issues that I've already discussed in terms of references to morphine milligram equivalents, some concerns that the recommendations were unnecessary or were too cumbersome, and some views that we should become more particular in giving guidelines to particular clinical settings. It's important to understand that these are guidelines, they're not clinical directions. They are aimed to be at a higher level and not to be overly prescriptive. So we are very grateful for all of the comments that have received, for the great interest that has been shown in this project. And if I can say personally, very grateful that all the people who have participated, you could see that the drive here is to make these guidelines better. And I think we share that goal. And so we're interested in going through this final stage. Now, what we plan to do after the comments here is we will then very carefully review the written comments and everything that is said here today. We will go back with the staff, the task force, and our subject matter experts. We will then aim to have a final document. That document will not be ready for the next board meeting, which is literally in just a couple of weeks' time, but it was anticipated that it will be presented to the first board meeting in the new year. And then in 2023, we can finalize those guidelines. As I have said previously, the guidelines are extremely important. They will be sort of the bedrock on how we move forward here. But that's not the finish of our work. What we then need to do is to engage in very intensive outreach with the stakeholders, with the professionals, to meet them personally and to deliver a very clear message that these guidelines are there to promote the highest standards of practice and to deal with the problems of access. They should be seen as empowering physicians to care for some of our patients who are the most vulnerable and have the most challenging circumstances. So again, we issue the guidelines and then we will follow that up by engaging in a very concerted public outreach, which we hope will reach a wide range of stakeholders. I think at this point, we are now ready to go to our open discussion of the draft guidelines, item number 4. Again, the purpose here is to make these guidelines as effective and as clear as they possibly can. We welcome all your comments, the ones you've given so far, the ones you will give, and it would be very helpful to us if you have specific suggestions. If you could make reference to the documents in terms of what sections that you're talking about, so just we can be very clear in terms of what your recommendations are. With that, Sean, can I ask you to begin the public consultation?
Yes, Bill, thank you. And for all the public members out there wishing to make a public comment, we've activated the raising hand feature in WebEx. Also, the Q&A window is there. If you can't find the raising hand button, you can go ahead and type just anything into the Q&A window and we'll call on you by your name so that you can make a public comment that way. And I do see a few call-in users that indicating that they're called in by phone and not connected to a computer. If you're called in by a phone and you'd like to make a public comment, you can press *3 on your phone in order to toggle raising your hand that way as well too. So,
Sean, before we start the public comments, I just would like to also make a short. I mean, I think there's a lot, as Bill alluded to here. There is going to need to be a lot of work, both internally, not only at the medical board meeting, but with our partners at the Health Quality Investigation Unit and the Department of Justice. We're also going to be obviously needing to reach out to our partners in pharmacy and the health plans at all levels there, and because this is just the beginning of a process, and this document will be, if it's going to be effective, it's going to need to be seen as a tool that can be used across the spectrum of needs as well. And so, we will, that's a next level of function that will need to be initiated. But these comments that you have today about the detail of the document itself are extremely important. So Thank you. And with that, Sean, I'll be quiet and listen.
Thank you, Dr. Thorpe. And just to, I had a question here already from a public commenter. The time limit will be 3 minutes per public comment. We will give you a verbal note when there is 30 seconds remaining and then ask you to please conclude at the 3-minute mark. So first,
Sean, just one other thing. Since we have a somewhat focused agenda and we have a number of interested parties that some of them quite detailed, 3 minutes may not be enough in their initial comments, but will we allow them to come back to the microphone to finish up a comment if they were in the middle of it or something?
I'll leave that question for Carrie. I'm not, usually we would only allow one comment per.
And Dr. Thorpe, as the chair of this, you can allow some flexibility. The problem is that we have to be fair to everyone on the time limit. And so if you want to extend it to, 4 minutes for everyone, we can do that, or we can circle back around, time permitting, to let people speak again.
Yeah, I mean, I'm not sure how many are on the call. It sounded like there were like 12 to 14 people on the call. So if we did 3 minutes, that's.
We're up to 31 now.
Oh, okay.
Not everyone has their hand up, obviously, but
Okay, well, let's start out with the 3 minutes, and we'll see if we need additional comments later. My intent is to make sure that we hear everyone thoroughly and make sure that we get all the information we need from everyone that's there. And some have more information than others just because of their expertise. So anyway, all right, thanks, Sean.
Very good, thank you. So up first here we have Dr. Chen, and so when I call on you by name, you'll receive a prompt on your end to unmute your microphone. Looks like Dr. Chen got the prompt there. Are you there?
Yes, thank you. I want to extend my sort of appreciation for, is it Dr. or Mr. Presivka's comments on what has been done with these guidelines. They have been much needed, and I appreciate the direction they're going in. My name again is Dr. Trinyan Angie Chen. I'm Clinical Associate Professor of Medicine at Stanford. I am calling representing, can you all hear me, by the way? Okay.
We can.
I am representing a board member of California Society of Addiction Medicine. As part of their opioid task force, there has been some sort of comments that they wanted me to pass on of members who could not attend. I'm also part of the American College of Physicians as governor of the American Northern California ACP, and I'm an addiction medicine physician. And I practice addiction medicine and provide buprenorphine MAT treatment for those with pain and addiction. And so if there's only 3 minutes, I'm just gonna perhaps point to 3 main takeaways in the guidelines and ask if buprenorphine is parsed out differently in the guidelines. It doesn't seem to be viewed differently, and we request that attention be given to buprenorphine as something separate from the, for instance, morphine equivalent calculations. It's not a one-to-one, it's apples and oranges, it's not apples and apples. So that when you calculate morphine equivalents, let's say on the cures report, that not be viewed in a similar way as other full agonist opioids. And then, in the day and age after COVID, we have to really think carefully about mandating inpatient or in-person visits to discuss non-compliance. So if you look at page 12, it says they are recommending in-person meetings to discuss non-compliance. And so we want maybe some flexibility with this, because it's just very difficult for patients and what they've been used to now to do inpatient or person face-to-face visits. And then you know, we really, really must. If there's a take-home message that I want to convey amongst a lot of the addiction medicine physicians,
seconds remaining.
there needs to be a low barrier to buprenorphine access for both pain and addiction. Have I met my time?
Just have 20 seconds left. I'm sorry.
Yeah, I just want to quickly convey a story. My colleague who got surgery, so this is a doctor who got surgery in the hospital, could not get buprenorphine easily when she requested this for her post-op pain. She was allergic to Dilaudid and other full agonists, and getting buprenorphine was even difficult for her to obtain. I can't imagine for the, you know, lay person trying to advocate for themselves how they can get that, and it's a much safer opioid. Thank you. I will close. Appreciate the opportunity.
Thank you, Dr. Shen. Sorry, let's drop down here. Next up, we have here Kristen Ogden. Kristen, you should be receiving that prompt on your end.
Hear me?
We can. Go ahead, Kristen.
Thank you. My name is Kristen Ogden, and I speak on behalf of Families for Intractable Pain Relief. Thank you for the opportunity to comment. Your revised updated guideline still does not acknowledge the existence of the patients I represent, those with constant, extremely severe pain, many of whom require high doses of opioids. I want to be sure you know there is a pain care crisis taking place this very day in California as I speak. Dr. David Bockoff of Beverly Hills was visited by the DEA on November 1st and given an immediate suspension order. Doesn't matter what anybody said about don't cut people off immediately, the DEA is doing it by what they have done to Dr. Bockoff. He is not able to write prescriptions for controlled pain medications for my husband, Louis Ogden, nor for many other patients with severe constant pain. 2 people have already committed suicide as a result of the action against Dr. Bockoff. I fear there may be more deaths in the very near future by suicide, cardiac arrest, or stroke due to the shock of abrupt cessation of prescribed opioids or other complications of untreated severe pain. Some patients were almost out of medication on November 1st, the day that this visit from DEA took place. More are running out of medication every day. Patients and advocates have called numerous physicians asking to be taken as patients. Doctors are not returning calls. Mr. Prasivka, California physicians are not returning to the practice of pain care, and any update to your prescribing guideline is not going to make that happen. I very much regret that I have not yet completed, therefore not submitted, my written comments because I have been engaged full-time as an advocate for the past 2 weeks, doing whatever I can to assist Dr. Bockoff and his staff and the affected patients. We've asked you many times in our letters and oral comments to stand up, to push back, resist the actions being taken by the DEA in the state of California. Capable, compassionate physicians are being harassed for taking patients with severe constant pain and treating them to enable pain relief, improve function, and improve quality of life. The DEA is ignoring California's Pain Patients Bill of Rights and Intractable Pain Treatment Act. This time, the situation may involve a smaller number of patients than the death certificate project, but it is all happening right now. It's happening again. It's time for this board to challenge the DEA's actions by going to upper levels, whatever it is you have to do. My husband and many other people's lives are on the line in the very near future.
30 seconds.
I heard a quotation recently by a person whose name you will all recognize, Michael J. Fox, who has been a major advocate for Parkinson's. What he said is, the patients who suffer with the illness are the subject matter experts. I really feel and was disappointed that throughout this process, you all have not asked us to be subject matter experts. Dr. Sean Mackey is an excellent pain specialist, very knowledgeable, and certainly a subject matter expert overall, but I do not believe he is an expert in how to treat the people like I'm talking about, one of whom's already died, and his wife, who wasn't going to go on without him, a double suicide. And we have many more lives on the line, to include others who often show up here at these meetings to speak. I ask for your help. Thank you for the opportunity to comment.
Thank you for your public comment. Next up, we have Anne Fuqua. Anne, you should be getting that prompt on your end.
into it, but I have some concerns. I hope that I will be able to find a physician willing to treat me so that I can benefit from it. This is not an action of the board, but we have a right now. I am one of the many patients.
And we're having a really hard time hearing
you.
you. Can you get closer to your source of internet,
Sure.
your
Is
Wi-Fi
that
or anything?
better?
It sounds a little better. Yeah, I'll go ahead and restart your time.
Okay, I apologize. I'm so sorry.
Much better.
We have a crisis that is occurring right now. It may not seem as large as COVID, but to the 200 or so patients of Dr. Bonkoff and myself, I realize this action. The problem is that other doctors are too fearful to take on the care of high dose patients, even as advised by the newly revised CDC guidelines. California needs language similar to that which has been adopted in Minnesota. I am 42. I've had a wonderful life until 2 weeks ago. Even with the assistance of a methadone clinic, I'm not experiencing withdrawals, but my previously well-controlled pain and dystonia are now uncontrolled 24 hours a day. Methadone isn't something that works well with my body, and I have gone from having a wonderful life to just existing. With my previous regimen, I hadn't needed an increase since 2008, 14 years ago. I have a long track record of adherence, functional benefit, and zero side effects. I physicians should feel confident treating, yet they are afraid to treat. I would ask that protections that protect that allow to feel confident treating future patients like me without fear. There have already been at least two deaths, one a patient, one his wife, as Kristen mentioned, without help, there will be more. I love the life that I had until 2 weeks ago, and I want it back. I don't want to die, but I fear these efforts won't come soon enough for me or others. So I would ask the board to examine and consider invoking any emergency protections you legally have the authority to offer physicians that would encourage them to treat opioid refugees like myself. And as Ms. Ogden said, to push back against the DEA. We're human beings. I just want to live my life. Lewis Ogden wants to live his life, and so many others. We just need help doing this. Thank you.
Thank you, Anne. Next up here we have Lucas Evanson. Lucas should be receiving that prompt on your end. Are you there, Lucas? Yeah, go ahead. We can hear you.
Okay, thank you. Good afternoon. My name is Lucas Evanson, Associate Director of Strategic Engagement for the California Medical Association. First, we'd like to thank the task force for clearly and carefully considering the testimony provided on the first draft of the guidelines. There are several improvements made in the new draft guidelines. We appreciate the task force bolstering the recognition that delivering appropriate pain care is complex by acknowledging that actions undertaken by the board could have contributed to barriers in access to care. We also appreciate the emphasis placed on clinical judgment as the basis for prescribing, the clarification that fail-first is not a requirement for prescribing, and the removal of the overly restrictive timelines for the patient assessment. We also appreciate the opportunity to provide additional comments. Upon review of the latest revision, CMA suggests the following additional amendments before the guidelines are published. First, on page 6 of the draft guidelines, we ask that the recommended practices for the management of patients with pain section be removed, as it's unclear what practices this section is referring to and could run counter to the board's previous guidance, which instead highlights physicians' clinical judgment and the individualized medically necessary patient-centered decision-making. Next, on page 13, under the urine drug testing section, the guidelines have been changed to require annual urine drug tests. This is more stringent than the original draft, which suggested consideration of at least annual drug testing. Additionally, the guidance conflicts with the now finalized CDC opioid guidelines update, which recommended that clinicians consider the benefits and risks of toxicology testing to assess for prescribing medications, as well as other prescribed and non-prescribed controlled substances. CMA recommends that this section be updated to align with the new CDC guidelines, specifically recommendation 10. Finally, we would note an incomplete sentence in the acute pain section on page 19. The sentence that begins when implementing an acute pain management plan, we believe was intended to end with the words is recommended, as it did in the prior draft. Again, we would like to thank this task force for all the work that has been done to update the opioid prescribing guidelines and appreciate the opportunity to provide additional feedback.
Thank you for your public comment. Next up here, we have a caller from the 951 area code. Caller, you should be able to press *6 to unmute. You should be being prompted on your end to do so.
Good afternoon. This is Monty Goddard. Can you
We
hear
can
me?
hear Monty. Go ahead. Yeah.
Excellent. I just have to begin with my sincere thanks to Dr. Thorpe, Mr. Brooks, and Executive Director Pacifica, and anyone else that's been involved for this second Interested Parties meeting and the improvements related to MMEs in this current draft. I now detect the only MME language in this updated draft is a reference to the CDC fact sheet for calculating MMEs and offering a prescription for naloxone when prescribing a patient a daily opioid dosage of 90 MME or more. This is a huge improvement. It's a noticeable change from the last draft. I appreciate it. Thank you. However, as the task force and some other board members correctly voiced at your July and the full board's August meetings, and I'll add in the introductory comments to this meeting, the updated guidelines alone will not be enough to correct the wrong done to the pain community since 2014. Concerns including overcoming physicians' fears for prosecution in prescribing opioids and pharmacists in filling opioid prescriptions. Another valid concern voiced by the Vice President, Dr. Hawkins, related to getting insurance companies out of practicing medicine. You emphasized an aggressive outreach education campaign must accompany the board's release of the updated guidelines. I wholeheartedly agree with this and suggest there's an additional step the board could and should take. I've already suggested to Senate Majority Leader Mike McGuire's staff on October 25th and to the Medical Board's Legislative Proposals and Priorities Task Force this past Wednesday. California needs to amend its Pain Patient Bill of Rights by adding wording from Minnesota's recently enacted Pain Patient Relief Law, the same law that Ann Fuqua just mentioned. 3 minutes does not permit me to go into detail, so I have submitted written comment with the background details and the benefits, which I hope you will all examine. Amending California's Pain Patient Bill of Rights to explicitly protect physicians and pharmacists, as Minnesota has done, will go a long way in allaying doctors' and pharmacists' fears around prescribing and filling opioid prescriptions. It will also send a powerful message to health insurance companies and pharmacy and their pharmacy benefit managers. Your updated guidelines and improved Pain Patient Bill of Rights would be a powerful combo for good. Please make it happen. Support the legislature amending California's Pain Patient Bill of Rights. The only thing we'll have to worry about after that is the sword of Damocles that I mentioned the first time I commented on this to the board, and that is the DEA. Something has to be done with those folks. Thank you.
Thank you for your public comment. Next up here, we have a individual identifying themselves with the name Medical Board of California. Should be receiving a prompt on your end there.
Good afternoon. My name is Misty Hoffman, and I'm a disabled chronic pain patient. Thank you for allowing me the opportunity to speak today. I've read the draft of the updated opioid prescribing guidelines and appreciate you taking the time to update those guidelines. However, there remains in the guidelines a very problematic part, of which is, in my opinion and many others' opinions, is the very crux of the problem that was started by the CDC. That is any mention of MME numbers and thresholds. Although the language in the revised CDC guidelines is softened, they too left MME mentions in the guidelines. Not only are primary care physicians operating under those numbers, if they're willing to prescribe pain medication at all, but pain specialists, oncologists, and surgeons are using those MME thresholds as a hard limit, whether just suggestions or not. As the DEA, state medical boards, and state and local law enforcement have used those MME numbers as de facto law and actually cited them in investigations. As per the guidelines, my PCP referred me to a pain specialist when they came out, and then later that specialist was so scared of getting in trouble by the DEA and state medical board that he said all patients would be cut to 90 MME or under by the first of that year. He later completely dropped many patients, including me, for no reason other than fear. My PCP took my care back over, but has explicitly stated that he will only give me up to the 90 MME limit until he is certain he won't be persecuted for giving me what he believes I actually need. I'm bedridden most of the time now. I can't even bathe every day or even every other day. Like many other chronic pain patients, I have already tried every non-narcotic option available to no avail, including medical implants that are now endangering my health and life. Before my pain specialist dumped me for no reason, he told me that I can say I'm an addict and go to a methadone clinic. When I replied no, because you know I'm not an addict and I don't want that on my medical records, he replied, just joking. But this isn't a joke. It's my life. I want to live, but this is no life. Due to pain, I'm losing weight rapidly, having chest pains, and losing hair. I want to live, but not like this. I was doing fairly well on my medication before the guidelines destroyed my life and the lives of many other pain patients. The MME limits and the CDC chose have been proven over and over now to not be scientifically supported in any way and an arbitrary choice. 90 MME is not adequate for many pain sufferers for many reasons, including pain level, medication, metabolism, etc. More and more is coming out regarding the flaws in the CDC guidelines, both scientific and statistical, as well as some very shady actions that led to those 2016 guidelines. If you leave the MME numbers in the
30
guidelines,
seconds for me.
you will allow pain patients, including those dying of cancer and in hospice, to continue to be subject to government-sanctioned torture, lest they go to the streets for relief, possibly ending up dead from illicit fentanyl overdose, or they commit suicide like so many have already. Please remove the MME numbers and allow doctors to treat each patient individually and accordingly. Thank you. And I'd like to add about the Minnesota new legislation. If California could do something like that, it would be amazing. Thank you.
Thank you for your public comment. Next up here, we have Richard Lawhern. Richard, should be receiving that request on your end.
Am I coming in?
We got you, Richard. Yeah, go ahead.
Okay. Good afternoon. I'm Richard Lawhern, PhD. I'm a subject matter expert on public policy for regulation of prescription opioids. You have already posted my 6,300 word referenced paper to the comments prior to the meeting. I thank the board for making review of the prescribing guidelines for controlled substances as transparent as possible. However, I find that your second draft is still very far off the mark. You need to revise this document substantially to protect clinicians from persecution for simply treating patients' pain. In 1841, Scots journalist Charles Mackay penned the phrase, "extraordinary popular delusions and the madness of crowds." This is an apt description for most dominant narratives on the supposed U.S. prescription drug epidemic and for the CDC practice guidelines. Unfortunately, the California guidelines in second draft continue to suffer from many of the same deep misdirections. The board needs to read an August 2022 reanalysis of CDC mortality data by Larry Aubrey and B. Thomas Carr in the journal Frontiers in Pain Research. They demonstrate that there has been no cause and effect relationship since 2010 between rates of opioid prescription and either hospital admissions for opioid toxicity or opioid-involved overdose mortality. Writers of the 2016 and 2022 opioid guidelines were fully aware of that contradiction when they published. In my view, the CDC outright lied about cause and effect in overdose deaths. I represent hundreds of thousands of Californians today being denied pain care. Many general practice clinics now refuse to accept new patients in pain management. Most remaining clinics are involuntarily tapering patients and killing some of them. Patients are being sent home after major surgery with Tylenol as their only pain control. The second draft of your guideline will reliably make their condition worse. The term risk appears over 100 times in the California guidelines second draft, often in ways that bear very little relationship to clinical practice. However, the board seems to have missed a basic reality. There are no validated profiling instruments that accurately predict which patients are at risk or may benefit from opioid therapy. This includes the risk instruments embedded in your present PDMP. Your second draft
30
will
seconds
leave
remaining.
Your second draft will leave clinicians vulnerable if they prescribe opioids to any patient at any dose for any duration, and the slightest thing later goes wrong. You must therefore further revise this document to protect doctors from unjustified persecution, not to overhype fictitious risks. I offer my services to support the board in further discussions. Give me a month and I can rewrite your guideline from the ground up. It needs to be. Thank you for your time.
Thank you for your public comment. Up next here we have Michael Comensa. Michael, you should be seeing that prompt on your end. All right, one more time here, Michael. There you go. Look like your line's open.
Hello.
Yes, Michael, we can hear you. Please go ahead.
Okay, good. Thank you. I'm here on behalf of my sister Mary, who is a chronic intractable pain patient for over 30 years. I will support the things that were said by Ann, by Kristen, by Lucas, and others here relative to the fact that doctors are put in fear when they're trying to treat the patient in the best way possible. As was mentioned before earlier, we have a crisis right now. Dr. Bakoff, who has been training my sister for well over a year and a half, has now been told he cannot prescribe any medications, Schedule 2 or otherwise, for whatever reason the DEA seems to have come up with. The Medical Board of California needs to do something to hone in the DEA and allow people like my sister and the others on this call who have already spoken to get the pain medications that they require to let them have a certain level of quality of life. And let me add, my sister has tried everything otherwise. She's tried acupuncture, she's tried Botox, she's tried injections, anything that's been on the menu for doctors to try to alleviate their pain have not been worthwhile or have been effective. The only thing that's been effective has been the opioids. And if she could get off them, she would. But that's the only thing that relieves her from pain. And my fear is, as my baby sister, she's 67-year-old grandmother. I'm 71. I'm going to be 71. I don't want to lose her because the pain is so intractable that she takes her own life. And as other people have already mentioned, there's 2 people that have already done so. So whatever action has to be taken on an emergency basis to allow all of the people that are joining this call and the hundreds of thousands, if not millions of people that have intractable chronic pain and cannot get any relief except through the use of opioids, please, please do something to allow them the quality of life that they deserve. Thank you.
Thank you for your public comment. Next up here we have Velvet McKenzie Gray. Velvet, you should be receiving that prompt on your end.
Much of my comment has actually been covered. Can you hear me okay?
We can. Please go
Okay,
ahead.
great. Much of it has already been covered, so I'm going to pivot just a little bit. I'm a pain patient. I'm a disabled person, and I recently got into pain patient advocacy because of what was done post 2016 CDC guidelines. Before I do that, can you see the comments of the people who died by suicide? 571st Air Cavalry Combat Medic and my good friend Jason A. Matus died by suicide for lack of pain care. Jay Lawrence, Brent Sloan, Danny and Gretchen Elliott are who they are talking about. Navy veteran Gary Stephen Presley, Tom Bellinger, Trinity Lillian Graves, who was 18 years old and had untreated severe endometriosis pain, Bruce Graham, and Bob Mason. These are very real pain patients who died from suicide. And while this might be kind of a switch up for a pain patient advocate, I want to talk about the providers as the providers have spoken on this meeting, because it is provider fear that is getting in the way from us as pain patients being treated. If this document does not protect providers, pain patients simply aren't going to get treatment. I was recently seen by a new pain provider, and the exact quote to me was, "You just need to wait until the pendulum swings back." Fear is now the driver within the communication between patient and provider. And when fear is driving that communication, health is out the door. It's just simply out the window. We do not feel seen or heard at all. I am a compliant patient. I started at Mercy Pain and moved on to a primary care. But now, like was mentioned in the July video from another patient advocate, we had this opinion as pain patients that if you had any treatment at all, keep your head down. So I've spent 6 years keeping my head down. That is not a good and valid and trust building communication between me and my provider, who I like very much. I like my primary care very much. But I was so terrified every time I would go to an appointment or a pharmacy, which needs to be part of these guidelines that pharmacies are not filling. That aside, 3 days of panic, anxiety, and stress with a provider I like. That is not, my health is not driving that communication at all. And I do web advocacy. I have a TikTok. It sounds silly, but my entire comment section
30 seconds remain.
is people in pain, because fear from the patient and fear from the provider is driving our relationships. We have to protect providers in order to protect patients. Thank you for your time.
Thank you for your public comment. Next up here, we have Rosie Arthur's daughter. Rosie, you should be receiving that prompt on your end.
Like many of the other people, I agree with everybody so far on a lot of these issues. Let me start with the, where to start? With the Minnesota law. We don't have to do that. Those laws and protections are already on the books. We don't have to reinvent it. I have been saying for the last 8 years, and every time I come to one of these meetings, that you need to link the pain patients' Bill of Rights and the protections for the doctors. So that's very clear that that protection is out there. Then in your prosecuting cases, you need to look at those and not selectively look at the law so that you can convict a person or discipline them for providing medication when it's to a person with chronic or intractable pain. But it's done. The other issue is the word risk. Every time you see that risk, the word risk, that means that's the best interest of the insurance companies. It has nothing to do with the pain patient or the consumer. That's where that comes from, is from risk, either from paying for safer medications, doing a simple test that only has to be done once in a person's lifetime to see how their medications are metabolized, etc. No. It's much easier for the insurance industry to not have to deal with pain patients at all or their medications so that they don't get sued or they don't pay for the service. That's where the bottom line is. Now, no unintended consequences. When you see that word risk throughout your guidelines, has nothing to do with the patient. It has nothing to do with the provider trying to provide treatment. Subject matter experts. There are subject matter experts that are begging to be on your committee. People who are not beholding to insurance companies or the medical board or whatever for their livelihood today or maybe in the future. Because anything they say and do now will be held against them later, even as a subject matter expert. So you need people who have no ties. It's very important. I've recently given reference to guidelines, existing guidelines that existed prior to 2014 that address how medications are metabolized. A number of people are dying simply because in your eagerness to get them off of opioids, you're actually giving them contraindicated medications that are killing them and driving them to suicide. This has to
Please conclude.
stop. Okay? And I hope there'll be another chance to comment because there's more. And nobody's listening to us. You can listen to us, you can have meetings, but beyond the words and taking a few minutes to do a meeting, nothing is done with that input. You're taking 40-year-old guidelines before the DEA.
Thank you for your public comment. Just need to be fair to all speakers that we're at 3-minute limit. Dr. Thorpe, I do not see any additional hands up at this time. If you'd like to take public comment, I can go ahead and, oh, and we just had several more come back up here, so, okay. Let me lower that one. All right, next up here we have Tom. Tom, you should be receiving that prompt on your end. For individuals raising and lowering your hands too, all it does is lower you down into the queue. So just put your hand up one time and we will call on you as we get through the queue here. So Tom, are you there? Looks like your line's open.
Yeah, I had a prepared comment, but I got a call earlier today, a response from the California Society of Addiction Medicine. And I had asked them if they had gotten a response from the California DOJ regarding their March letter to them regarding, let me see, it was NARCS care scores and the DEA, and they were asking the California DOJ to respond to 7 different domains of questions regarding the NARCS care APRA scores and their application of it. And I wanted to see if they'd gotten a response from the California DOJ, and they said no, they hadn't. And so they wrote this letter in March, and they were citing works by people like Jennifer Oliva, who had written. I'm sorry, I'm sort of on the fly here. Jennifer Oliva is a well-known health attorney. She's at UC Hastings Law School in San Francisco now. She wrote a paper called Dosing Discrimination, Regulating PDMP Risk Scores. And they also cited an article by Maya Slavitz in Wired magazine called The Pain Was Unbearable, So Why Did Doctors Turn Her Away? And they're attributing this to these applications of the DEA and using the NARCS care system. And anyhow, they had come to the conclusion that based on some work done by Professor Angela Kilby at Northeastern University that, well, anyhow, they said it is possible that the DOJ nationally has aimed at the wrong targets. And they cite the rise in, they cite the opioid prescriptions being forced down since 2012, along with the rise in opioid overdose deaths become significantly steeper. Anyhow, I had asked if they had gotten any response from the California DOJ, and this very nice lady said no. But she also mentioned that they had not got a response from the Medical Board of California, which, and I'm looking at the CC on their letter. I don't see you listed, so I just wonder if that was a mistake. But I don't know if the board has gotten this letter, because I don't see it. They're contacting all the leaders of the California legislature, health organizations around the country, the American Civil Liberties Union, Drug Policy Alliance, the New York Times, Los Angeles Times.
30 seconds remaining.
But I don't, anyhow, so I would hope that you guys would take a look at this letter, because it addresses the issue of the DEA attacking doctors. And there's that case that people have cited about the 2 people who committed suicide, which I think is incredibly, it's just so tragic. And something else that I want to reiterate, the addition of the Minnesota language to existing California law. That would be a good way to maybe move things along. But you could also really influence the legislature too in moving that along. But take a look at that California Society of Addiction Medicine letter. Thank you.
Thank you for your public comment. I've got individuals request. I don't know if we're going and doing a second round of calls. So if I'm lowering your hand, it's because you've already had an opportunity, and then we get the end. We'll see if we have extra time. Next up here, we have Sarah Newman. Sarah, you should be receiving that prompt on your end. Sarah, looks like your line's open. You there?
Yes, can you hear me?
We can. Please go ahead.
Okay. I actually was not planning on speaking, but I just felt like I needed to. I'm a pain patient. I have chronic Crohn's, fibromyalgia. I only have 27 centimeters of my colon left. And 6 years ago, with an abdominal fistula, I was in a hospital for almost 2 months. And during that time, I had an internist who I had never worked with before come into my hospital room several times and essentially scare me into getting off the opiates I was on and getting onto Suboxone, because it was supposed to be this thing that would make everything better, that would treat my pain, and it wouldn't be hurting my insides like I was being told that the opiates would do. 6 years later, my pain is not treated. I now have addict on my medical record. So to change back to opiates is going to be a fight, if I can even get that far. And now my teeth are messed up because of the Suboxone. So I know that the grand scheme of things is trying to keep people safe, but pain patients are a different category when it comes to opiate medication, and we need this medication in order to survive. I don't know what I'm going to do for my own pain management, but I'm still trying to help other people and advocate, and that's why I was here trying to listen so I could learn more. I guess that's really all I have to say. Like I said, I wasn't planning on saying anything. I just want you guys to know how these guidelines are affecting real people, and other things outside of opiate pain care just have not, they don't do the same. And now I have other problems on top of it that still won't get treated. Thank you for your time.
Thank you for your public comment. Next up here, we have Megan Rivera. Megan, you should be getting that prompt on your end. Megan, looks like your line's open. Are you there?
Yes, can you hear me?
Can. Please go ahead.
Hi, thank you for the opportunity to speak. I hadn't planned on commenting either, but I have been a chronic pain patient for over 20 years. I'm also a volunteer advocate, and pretty much everything else has been covered, but there were a few things I wanted to touch on in the document. And I noticed it a few times. In the beginning, it had mentioned certain things like specific aberrant behaviors, not necessarily being indicative of addiction, but of undertreated or untreated pain. That's also addressed in the Pain Patient Bill of Rights, which is wonderful. However, it goes on to discuss things like initiating opioid trials. And it mentions this a number of times, and I'm sorry, I don't recall where. And then it says after an undetermined duration, if it's not successful or doesn't provide relief to the patient, that the trial is unsuccessful and you should consider tapering or cessation. It doesn't discuss that could also be a result of undertreated pain. My concern is that a lot of physicians are going to see this as, well, we tried opioids once and it didn't work, so that's it. Where it could just be that it could have maybe been working, just not quite well enough. And this happens a lot with chronic pain patients, especially when they are starting opioids for the first time. This is something that I've experienced. It's something that I know a lot of patients that I've worked with have experienced, and that language can be very damaging. And as I said, it's mentioned multiple times throughout the document. And quite frankly, the majority of the document reads much less like a prescribing guideline for treating any type of pain and much more like a scary warning document for, how to not create drug addicts. And the whole thing is a very chilling document. It doesn't, yeah, there's too much risk and ooh, look out, and very little compassionate. We're trying to treat pain and do this in a way that
30
is
seconds remain.
less harmful than it has been in the past. And I would like to see that change, but I would very much like to see those specific points change, the verbiage change to maybe be less, a little more lenient. So thank you very much.
Thank you for your public comment. Next up here, we have Lewis Ogden. Lewis, you should be receiving that prompt on your end. There you go, Lewis. Looks like your line's open.
Can you hear me?
We can, Lewis. Yeah, there's a bit of an
Oh.
echo in the background. If you could turn down whatever speaker that would be, but yeah, we can hear you.
Okay. My name is Lewis Ogden, and I'm the husband of the first speaker, Kristen Ogden. So you know by now that another California pain management doctor was visited by the DEA and issued a stop prescribing order. This Dr. David Bockoff of Beverly Hills is my doctor, and he is now unable to write my prescriptions. Your attempt to bring more pain doctors back into practice is just not going to work. My wife and I called quite a few LA area pain doctors, and none of them have responded back to me. I think that the medical board needs to contact Governor Newsom and advise him of this terrible situation. Perhaps he could then contact the DEA and other federal authorities and tell them to leave California alone and stop the harassment of innocent pain management doctors. Dr. Bockoff has been practicing for 52 years, and to the best of my knowledge, he's never had any kind of complaint filed against him. I am what they call a legacy patient. I'm on a very high dose of pain medication and have been for the last 12 years. My dose of meds is what works for me. Lower doses do not. I'm getting scary low on my supply of pain medicine. To make this long story short, this situation has already caused, as you've heard, a double suicide, and something needs to be done, and I mean quickly, before it causes more needless deaths. Please contact the governor and tell them he must get into this situation and rattle a few chains in Washington, D.C. This harassment of pain management physicians in California must stop. I desperately need my doctor back. Thank you for the opportunity to comment.
Thank you for your public comment. So at this time, no additional requests in queue. There's one hand up now for someone who's already spoken. I don't know if you want to.
Okay. Well, Sean, it's 3 o'clock or just a little after 3. We're scheduled to go till 4. I think it's what I'm interested in hearing. I think I recognize this Dr. Bockoff's visit by the DEA has been extremely troubling. It's life threatening. Obviously, it's a very difficult situation for those people who are his patients, and he's not able to prescribe, and they can't find another doctor. I don't know that we need to hear that story another 5 or 10 times, but I'm not out of please don't misunderstand me. It's not because I'm not empathetic with the story. It's because we have a limited time, and I think we've heard that story, so we'll do what we can. But the medical board does not have authority over the DEA, and it's going to be a difficult thing for us to we can try to reach out to the governor, but that's probably not going to be an effective way of addressing the DEA either. Unfortunately, it's a very difficult situation. However, I am interested in hearing some additional comments on this document, and that is what we really are here to try to understand today, how we can improve the document. And so there are, what I would like to see, if it's still possible, there were a couple of people who I felt didn't quite get to finish their comments. And you know, if they're willing to speak again, I would be willing to encourage that. I'm willing to hear other people, but if we're going to talk about this particular practice where the doctor's lost his ability to prescribe, then I think, you know, we need to save that till the end. But you know, I don't know how to.
I can just call in the hands that are raised, you know, Dr. Thorpe, and we want to go with another 3-minute time limit. Is that how you'd like to proceed?
That's fine. Yeah, let's do that.
Okay. So going back here to Michael Comensa. Michael, you should be using that prompt again.
Yes, do you hear me?
We can. Please go ahead.
Thank you. Well, then it's listening to the other comments from the other people who are obviously much more well-informed than I am. And as I stated, and you stated, sir, the fact that we had the situation with Dr. Bakoff, it goes in deeper than that. It sounds like on the document that has been drafted, there's all these words that talk about risk, and I would agree with that. That just gives excuses to insurance companies, et cetera, to not have the medications prescribed at the level that the clinician feels they should be for that patient, looking at the patient as a whole, and consequently it creates the problems that we've just described. More so, and I'll bring it back to just, let's bring it to real life. Working on behalf of my sister, I've called USC, UCLA, Cedars-Sinai. Neither one of them in their pain clinics have indicated any indication that they might be willing to prescribe any opioids, which for a pain clinic seems unbelievable on my part. I'm now looking outside of California on her behalf to see if there are other doctors out there. So, as people have already stated, whatever you can do to make these guidelines for California not only beneficial to the chronic pain patients, but also to the clinicians that want to prescribe, want to give the best care, but are living in fear because of these other agencies that, for whatever reason, don't want to have a level of understanding that this is what these pain patients need. And as far as the DEA is concerned, let them go after the Mexican cartels and those guys and leave the chronic pain patients alone. Thank you.
Thank you for your public comment. And next up here we have Susan. I'm just going to send that request to you now, Susan.
Matter expert, which I think is what you're wanting to hear from. But I am a pain patient, and I do have a comment specifically on the document. What I'm finding to be the biggest issue with the CDC and with the California guidelines is the MME. The doctors, whether they're supposed to or not, are taking that as law, and they're saying that in the appointments as the excuse for reducing medication when asked to be accountable. I have several conditions. I've been on stable pain medication for over 15 years. I'm 42. I have a son. And because I've been tapered, I'm now bedbound, and we had to hire somebody to take care of him. My pain clinic has 17 offices in California, and I'm so scared of what's going to happen because they've already tapered every single patient in 17 offices, regardless of your conditions. They're not looking at the individual. They're looking at the MME. In 2016, we were immediately tapered to 90 MME, no matter what your condition, no matter what was going on. No questions, 90 MME. Even seeing the 50 MME in the revision documents for both the CDC and California, immediately the tapers began in all 17 offices. This is all throughout the entire state of California. People are going to die. They are not looking at the patients. They are afraid they're going to get arrested. These doctors take meticulous records. They have hundreds of pages of my medical documents with MRIs, testaments from specialists about how much pain I'm in. They don't care. They're afraid they're going to get arrested. And so it just, the MME is the big thing. And then also, if you could help the physicians understand that these are guidelines. And I mean, I guess they just won't believe it if they are told they're not going to have the DEA show up, because that's not on you, but it's their fear. And it's just, it's ruining lives, and it's scary. And it just, so I guess the MME is the big thing. And this is across the chronic pain community. And then also working with the physicians on how to handle patients that have these severe, I have adhesive arachnoiditis, I have Ehlers-Danlos syndrome, I dislocate acutely multiple body parts a day, and I'm not going to have pain medication. I'm going to end up in the emergency room multiple times a week.
30 seconds for me.
And this is all many chronic pain patients that are at these 17 offices. And I feel like the physicians have their hands tied, and we just need to help them figure out how to help patients without treating these as law, because they are still citing them. They don't know how much I know about it, but they're still citing it as law, saying I have to do this. It's the law. So, and this is in 17 offices in California. This is thousands of patients that are being force tapered. And yes, they're doing it slowly and they're doing it responsibly, but there's no input. There's no collaboration with the patients at all. It's just scary. So anyway, that was all my comments. Thank you very much.
Thank you very much. Next up, we'll go into the 916 area code. Caller, you should be able to press *6 on your phone in order to unmute.
Hello, can you hear me?
We can. Please go ahead.
Okay, I too did not plan on speaking. I'm not good at it, and so please excuse my fumbling here. But I felt like I had to, because in the beginning, you stated that one of the things that you would be doing would be speaking with DOJ about the revisions in the guideline. And I just wonder, why DOJ has input in this. They are not physicians, and they should not be practicing medicine. And I think that's a big part of why the doctors are so afraid, is because cures is being overseen by law enforcement. We need to get cures out of law enforcement hands and back into healthcare professionals' hands. And if you do that, I think that a lot of the fear will be reduced for the physicians. You cannot have law enforcement dictating healthcare. You just can't. And that's a huge part of it. And that's pretty much all I had to say. Thank you.
Thank you for your public comment. Excuse me. Next, we'll go back to Kristen Ogden. Kristen, you should be receiving that prompt.
Thank you very much. Can you hear me?
Can. Please go ahead, Kristen.
All right. This is Kristen Ogden. I want to say, in case I didn't finish my statement before, that I do plan to submit my additional written input as soon as my time allows, and I will try to put that close to the top of my list. I want to say that I endorse and support the comments by Anne Fuqua, Richard Lawhern, Lewis Ogden, Monty Goddard, and others whose names I didn't get down. I do agree with the concerns expressed regarding doctors, pharmacists, and other providers, and I agree with the concerns about the insurance companies. I very firmly believe you could have done a little more in your draft, back to your draft, to acknowledge the existence of severe, long-term, incurable chronic pain patients like my husband and Anne and all these others. We gave you some specific recommended language that we thought would help define these patients and would provide at least some coverage for them. And I also have previously said that if you find that you just can't do that, then try to take action to establish a special program, a registration system, something that would allow these patients to identify themselves and be confirmed, and then would allow doctors to sign up to take care of them. Right now, there are no doctors, and these are among the sickest patients there are. Your guideline could say something about that, and I really wish that you would. Also, I want to say again that you're missing the biggest opportunity to learn more about these patients by not establishing as subject matter experts some of the members who have been speaking in these meetings. You don't know what this kind of severe constant chronic pain illness is like if you haven't had it or lived with it. And I urgently ask that you consider designating subject matter experts and inviting them to be treated as equals in the dialogue. I very much appreciate that you've had 2 meetings and you've published a second draft. Those are things we asked you to do. But your doctors, the people that you pull in, unless they are people who have treated patients like my husband and Anne and the gentleman who committed suicide, they aren't really a subject matter expert. I know that Dr. Sean Mackey, he himself, I think, knows he's not really a subject matter expert because Ms. Fuquay told me he followed her out of an FDA meeting where we both spoke in 2019, and he was there as a panel member, expert committee member, and he followed her out to ask her more questions about her illness and what helps it.
30 seconds for me.
So I think I must conclude, as much as I admire him, that he admits to not really being a subject matter expert on how to care for this subset of patients. So please take a look back at the earlier input we provided. I will work to complete my second level round of input and get it to you as soon as I can. And we do appreciate very much including us, having these meetings and publishing a second draft, but we wanted and we need more real participation than that so that you will understand these patients. Thank you very much.
Thank you for your public comment. Another request here from Richard Lahern. Richard, I sent you that request. You should be.
Yes, I am here indeed. By way of follow-up, I would like to speak to the science that needs to be incorporated into the guidelines you're working on. One of the things that we know is that almost all of the trials literature on opioids suffers from the incorrect assumption that randomized double-blind trials are the standard of care or the standard of assessment. For pain patients, they aren't. In fact, what is needed are varieties of enriched enrollment randomized trials, because in standard randomized trials, which is the great bulk of the literature on this, the placebo arm suffers from tremendous dropout rates because pain patients can't stand the tapering they go through in order to be trialed in a placebo arm. The CDC has regularly conflated the absence of long-term trials on opioids with proof of absence of effectiveness. That's been pointed out for the last 6 years in multiple sources. I would also suggest that we know that due to genetic polymorphism in the expression of the liver enzymes that govern opioid metabolism, there is at least a 15-to-1 range in minimum effective dose for opioids and for some other liver-mediated therapy treatments. We also know from reported and documented literature that the estimated risk of death from opioid treatment involving doses over 100 mmED is 0.25% per year. That level of risk is so low, and the number and variety of confounding factors in the design of protocols for trials is so varied that we literally cannot reliably estimate the risks of opioids for any individual patient, and we never will be able to. So when we focus on risk assessment, risk versus benefits assessment, what we have to do is learn by doing. And there is a framework within which this can be done. It's called the World Health Organization Ladder of Analgesic Pain Treatment. Gotcha. There are no scientific grounds for considering alternative non-pharmacological treatments as adequate a substitution for opioid therapy. and we now know that the crisis, whatever it is, resides mostly in the streets. Efforts to curtail it by constraining opioid treatment in the clinic are very unlikely to succeed. Thank you for the additional time.
Thank you for your public comment. Next up here, we have Rosie Arthur's daughter. Rosie, you should be receiving that request. There you go, Rosie, your line's
Hello.
up.
Yes, I'd like to continue on that same bent because it's what I've been talking about now for 8 years. Specifically, the metabolism problem that Dr. Lahern talked about is called CYP 450. There's a handful of culprits. 2D6, those mostly associated with sulfur-based medications and also has to do with bleeding, so that many of your non-opioid pain medications or your potentiators are in this class. 2C9, sorry, that's the one with the bleeding. 2D6 is the one with many of the pain medications, but other medications as well. 2C19, 3A4, grapefruit, we all know that one. And there's a couple more. And the chances of a person just having one bad gene for any one of these 5 is like 1 in 10%. Couple it with 2, you've got a big problem. I've had problems for years since I was a child. And recently for 2D6 and 2C9, I'm deficient. Yet every time I go to the doctor, they're always trying to put me on the wrong medication, a contraindicated medication. And you see that in the new CDC protocol where they're saying, well, if it's contraindicated, but they're not saying what it is. They know this. They've known this since 2000. This is not new science. This is old tested science, but it is ignored by the protocols and the guidelines that you are using. And this is a test, a one-time test that you can take, and then you have an idea, will these medications work? When you're talking about polypharmacy, maybe we have a choice in what we use. And even benzodiazepines, whoa, they're not all bad. Some are very good and are used. What has happened is in taking people off of their opioid medications that they've taken successfully for decades, they are then put on medications for depression. Bingo bango. Now you're giving them a problem. They end up with serotonin syndrome.
30 seconds
How's
remaining.
that treated? With Ativan. Okay. You can't have Ativan. You can't get treated. You commit suicide eventually. So, you get rid of the person, you get them out of the gene pool. So I guess that's a very effective thing. You also are not testing people for Suboxone, for ECGs, because it can also cause long QT syndrome. My son was sent home twice with serotonin syndrome, never told he had it.
Please conclude.
Twice with QTCs of over 550. He eventually committed suicide. So yeah, there's more than just those 2 or that 10 or whatever. There's thousands of people who are dying either from suicide or from
Please
heart
conclude.
problems because of these guidelines being misused.
Thank you for your public comment. Next up here, we have Tom. Tom, you should be receiving that request on your end.
Yes, hello.
Go ahead, Tom.
Yeah, I know that the board has been requesting for input on the specific details of the state guidelines, but the larger question I have about the state guidelines or federal guidelines is that nobody listens to the guidelines, and why does anybody think that any perfect version of a guideline, does anybody think that the DEA is going to pay any attention whatsoever to them? The DEA is not operating, and the CDC, they're not operating on a basis of science and research. In fact, why would they want to listen to arguments based on science research? Because those same arguments are just going to undercut their funding and their political positioning. The The inception of the DEA was under President Nixon, and John Ehrlichman, President Nixon's assistant for domestic affairs, famously said, "We knew we couldn't make it illegal to be either against the war or blacks, but by getting the public to associate the hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities." Did we know we were lying about drugs? Of course we did. So the DEA and in much parts of the CDC operate on the same kind of bigotries. And that's why I think, my opinion is that all the science and research that has been put up as arguments for the operation of those agencies has just gone ignored, because they're not operating on basis of science and research. So research and science arguments don't work with them. And that's why it makes it more imperative for the medical board, if they actually want to have people have access to good health care, they have to address this issue that lies outside the purview. As Dr. Mackey said in his talk to the board, he made a reference to Sacramento and the medical board looking outside the purview of its stated mission. So anyhow, I just wanted to reiterate that. Thank you.
Thank you, Tom. Next up here, we have Velvet McKinsey. Graham, Velvet, sending that request again. Velvet, I'm showing you.
Hello, thank you.
There we go. Go ahead.
Thank you for coming back to me. Give me a few seconds and I am going to bring it back to the guidelines that you are doing right now and the CDC guidelines as well. One of the things I'd like to say, the meeting we had before, I think it was Dr. Snook, said that pain care is dynamic and contextual. And I agree with that. And the pain providers are in a very bad situation right now. I'm a great example. I've been on 40 MME for over 10 years now. Even though I have mixed connective tissue disease and trigeminal neuralgia, none of that matters, but I have a bunch of things. However, the patients that I advocate for, I started to notice, I've got 11 patients back to therapeutical doses. They have far more pain treatment than I myself have after 10 years. I understand that that is dynamic and contextual and relationship based. But here's what I want to say about the California guidelines. I think it was Dr. Lahern just stated there is no reputable or even possible data demonstrating a valid and preventable measure to foresee substance use disorder. And the CDC admits this in pages 80 through 87. They consistently say the data is not viable, it is not valid, and it is evidence type 4. If the CDC's overall guidelines are going to influence and inform your guidelines in California, I implore this esteemed panel to please acknowledge that their guidelines are considered voluntary and that the data they provide, and they willingly admit it in pages 80 through 87, is evidence type 4. And they never compare opioid pain treatment to non-pharmacological treatment. They consistently say non-pharmacological treatment gives this amount of benefit. It gives a moderate or a minor benefit. But what they don't say is that they didn't compare, well, they do say it actually, they do willingly say it. They show that they didn't compare it to opioid pain therapy. They absolutely say in, I think it's 84, that they compared it to being left on a wait list, to massage, to inactive treatment, or to no treatment at all. So what they do in their pages with this evidence type 4 that they freely admit is they'll compare massage as a gain for pain control, but they're comparing it against being on a wait list. So California, being that, tinging on California exceptionalism here, but we are routinely a leader in from everything from technology to environmentalism. And we can be a leader on protecting pain patients and their providers. We have a chance to provide real solid evidence that protects both of them. The CDC did not do that in their voluntary guidelines, and they freely admit it if you read page 80 through 87.
30
they
seconds.
did not compare it to opioid pain control. They compared non-pharmacologic therapies to anything but opioid pain control. Thank you again for the second time. I really appreciate it.
Thank you for your public comment. Up next here, we have a call-in user from the 951 area code. You should be able to press *6 to unmute your line there if prompted.
Excuse me. Good afternoon again. This is not a prepared comment, so I won't be as eloquent as I usually deliver. But I've been participating, and this is Monty Goddard, I've been participating in these now for several months, and I don't want it lost because I think I'm a pretty good judge of character. And I think Dr. Thorpe and Mr. Brooks and Executive Director Pacifica, hearts and minds have been in the right place on this all along throughout this process. I think they recognize the harm. In fact, it was stated, I forget by which one of the individuals, that they recognize the approach the Medical Board of California took with the death certificate project was not a good move. And it created a lot of harm, and it caused a lot of patient abandonment. I won't go into the details, but I can personally attest to that in my wife's treatment. That said, I do acknowledge, as I said earlier, the comments and concerns. I've been laser focused since day one on the subject of MME because that has been the predominant harm creator for my wife. I use the term loss of life function, directly related back to the MME thresholds that were in the quote-unquote voluntary guidelines issued by the CDC in 2016. I think the board has done a pretty darn good job. Certainly, I agree with Dr. Lawhern, Kristen Ogden, and others. There's still more room for improvement. One of the things that I am most disheartened by is the recent events that did happen with Dr. Bakoff's office. I said in my public comment to the board back at their July meeting, no matter what we do here in California, the sword of Damocles is hanging over the heads of all of our physicians and pharmacists. And until someone gets the DEA under control, that's not going to change. And what I'm hoping is as the board does their improvements to their guidelines here in California, a huge state and a bellwether across the country, and they do the same thing if you guys follow through and we're successful in getting the state legislature to amend the California's Pain Patient Bill of Rights, that puts on record where the state of California.
30 seconds.
I have been in contact with my congressman's health legislative aide. He and I have a pretty good relationship. He's waiting for my report back on what happens with these most recent Medical Board of California meetings. Someone at the congressional level needs to start taking some action. In California, the Medical Board, our legislature, our governor needs to, our senators and our congressmen need to make that happen. So again, I just want to conclude this comment with thank you, Dr. Thorpe, thank you, Executive Director Pacifica, and thank you, Mr. Brooks, and any others involved.
Thank you for your public comment.
Thank you.
Next up here we have Lee T. Snook. Lee, you should be receiving that prompt on your end. Dr. Snook, looks like your line's open. Are you there?
Can you hear?
We can hear you now, Dr. Snook. Yes, please go ahead.
I'm sorry. Okay. I got called away in a deposition for the first part of the meeting, so I missed part of it. I'll make a quick point. As one of the contributors of 2014 guidelines, I made certain that we had the ability to do biological fluid analysis. I apologize if this has been discussed already, but that includes the option for blood levels. Unfortunately, in many patients that die in the course of a practice, which they do, the coroner's reports often will ascribe the cause of death as combined drug toxicity or synergistic effect of medications. So in my particular practice for the last 20 years, I've included normative data on blood levels of medications for my patients that have been prescribed multiple medications over time. And oftentimes those medication blood levels for those patients that are chronically administered those medications and demonstrate tolerance and clinical effectiveness, the medications exceed what a clinical pathologist may determine to be an overdose. So I would call out for us to try to get some normative data on this for all physicians, because I think there's a lot of causes of death that aren't necessarily drug overdose, but are ascribed to same, despite multiple medical problems that are evident for these patients. Those of us that have legacy patients have been in practice for, decades in my case, can testify to that. And I'm trying to call that information out of my electronic health record to help make that available. And bring that to the organized medicine, both the CMA and the AMA, to hopefully get some evidence to support that. So the ability for physicians to get blood levels are important if for no other reason, defensive reason, but also for monitoring of patients. And I just want the board to be aware of that. I again want to talk about the morphine equivalent doses, and I appreciate that the CDC did a lot of work on equivalency, tables. I really have to object to them as not being clinically relevant to many of my patients, particularly those on, let's say, methadone or fentanyl preparations, and they don't adequately take into consideration pharmacokinetic and pharmacodynamic variances in our patient populations. So I wanted to just make those 2 points. I really, really appreciate all the hard work that the board has done on our behalf to help us care for our patients. So thank you.
Thank you for your public comment. Here we have individual identifying as Medical Board of California again. Should be receiving that request.
Yes, thank you. Sorry about that. I don't know how that got identified as me. This is Misty Hoffman again. Thank you for the additional time to speak. I just wanted to add to what I was talking about with the MMEs, those being the very crux of the issues with the guidelines for the CDC and the state. They're causing the most harm, and add to what Dr. Snook and others have been saying about MME and drug metabolism and blood levels. Also, there are many pain patients that have had abdominal surgeries, including myself, like a full gastric bypass, and basically are part of our, I'm not a clinician, so I'm just going to put it in layman terms. Our plumbing has been rearranged and it's very malabsorptive, and unfortunately, we come to find out that oral pain medication does not work as well, not by a long shot, as well as the extended medications that are oral because of the malabsorptive issues. So before the CDC guidelines pulled the rug out from under my life, I was getting a fentanyl patch, and that worked extremely well because it didn't go through my digestive system. And so I wanted to, and that was taken away, and now I'm bedridden most of the time, as I mentioned in my earlier comments. But that's another thing that needs to be taken into consideration. Not everybody absorbs these medications the same, especially the oral medications, due to metabolism, liver metabolism, etc. But also if they've had any surgeries that change the way their body processes medication. So I just wanted to add that. And I really, really hope that something is done about the reference to the MMEs, because it's been proven over and over again now by different doctors and scientists that the arbitrary number that the CDC has chosen is just junk science, to quote Mr. Lawhern. Anyway, thank you for the additional time to speak. I appreciate it.
Thank you for your public comment. That line closed. Next up here we have Nurse Michelle. Should be receiving that prompt there on your end. Looks like your line's open. Are you there?
Yes, can you hear me?
We can, yes. Please go ahead.
Okay, great. Thank you so much for the opportunity to speak. Just a couple of things. One thing I would just like to say is that as a nurse, it's very upsetting that you know, I feel like it's upsetting that we're having to discuss this really. As doctors, we should all understand, and as medical professionals, what kind of pain that there could be, whether it's acute, whether it's chronic. What kind of pain are you talking about? As a nurse, I see people come into the hospital all of the time, and they require pain medicine, whether they've had abdominal surgery or they've been burned or been in a car accident or whatever the case may be. People are going to have pain, and we should be required to treat a person's pain. Allowing suffering is truly inhumane. And in the hospital, I'm able to grab the doctor and say, hey, this is the issue. And a lot of times they'll listen. The problem is that when you leave the hospital, you're required to go to a doctor's office. And I want to give you an example. My husband recently had surgery, 3 surgeries on his back just since last August. And just recently he had surgery, and his surgeon was only allowed to prescribe his pain medicine every 5 days. He wouldn't give him a month's worth. He gave him 5 days worth. And then when we went to the pharmacy to fill his medications, then we had insurance issues, and they didn't want to fill it every 5 days. And so then it's I just cannot explain to you. We're lucky to have it in the first place, but the problems of getting it filled, and then either the pharmacy doesn't want to fill it or the insurance wants it to last longer than the doctor ordered it. It's just such a rigmarole to get any kind of treatment at this point. I want to agree with the MMEs. I really do think that's the problem. The DEA weaponizes the MMEs and uses it against the doctors, and that's how they go after the doctors. Also, they will raid a doctor's office, and then the next doctor's office that people try to go to, that guy's going to be next if he starts taking on patients. And truly what it needs to boil down to is individualized care. It matters what's going on with you or your mom or your dad or your daughter or son. It matters if they're in pain. It matters if you're dying and you need pain control. It matters if you're just trying to do your job and go to work and support your family, but you have an injury. And the only thing you can do is get pain medicine in order to be able to function. People are having a hard time functioning without their medications.
30 seconds remaining.
They're becoming bedbound, and they're becoming depressed, and that's why people are hurting themselves. And I do want to agree that the real culprit is the fentanyl in the streets. Not that many people actually overdose on their medications. And thank you so much for the opportunity to speak.
Thank you for your public comment. Next up here, we have Joseph Kramer. Joseph, you should be receiving that prompt on your end. Joseph, looks like your line open. You there?
For being here today. I really appreciate the work you guys have put in. But I got to tell you, Dr. Thorpe, you know, I know you really care about this, but after reading the guidelines that came out, I was really disappointed because it looked like it was a copy of the CDC guidelines that they put out. And, you know, I was thinking tonight, there's nothing in there about the difference in the enzymes, you know, the breakdown, how people, everybody's different, you know. And we're letting people suffer. And by not changing that MME, you're putting forth fraudulent, because let's be honest, the stuff that the CDC came up with, it wasn't based on honest science. Okay, it was based on an ideology, and there's the other ideology of why the original intractable pain laws were put in place in the first, you know, in the beginning. And it was because Senator Green's wife was dying of cancer and he couldn't prescribe for her. Okay, and now we just thrown that all away, think that we can put a number on the amount of pills you can get. One pill, you can get one pill every 12 hours, 6 hours. Everybody's different, you know. So when is someone going to stand up for the patients that are suffering? Because I'll tell you what, the patients that are suffering, They're not the drug addicts out in the streets shooting drugs that you're going to have to worry about dying. Okay, 23 years, never needed an naltrexone pill or vape pen. And that's what doctors think now. Oh my gosh, if you're on opiates, you got to have a this and that. No, you don't. Not if you've been on long term, okay? In fact, the legacy patients are probably the last ones. They're going to die of an overdose, okay? Because they take their medicine like they're supposed to. They don't mix other drugs with it. They don't drink with them, okay? They follow their doctor's orders because they're suffering and they don't want to suffer anymore, you know? Um, I don't get this, how we're going to just let people, just they got cancer, so many horrible diseases out there, and they're learning more and more about more diseases and what's causing them. So when is someone going to stand up and say, you know what, that's hogwash, okay? And we need to protect the doctors. That's why one of the laws were made in the first place, to help protect the doctor and protect the patients. And this isn't doing it, you know? Look at all these patients now. They're out again, what, 200 more patients? That's in America. That is sad, and it's making us look bad. Okay, and
30 seconds remain.
this group prop, they ought to be ashamed of themselves. They really should, because they act like they want to do good for people, but actually all they're harming is people all across the country. I never seen so many people suffering in my life. They're causing mental anguish and trauma in families. Okay, and putting out garbage science. That's sad. It's really sad, and we can do better. I was hoping the California board was going to do better, so I'm disappointed, I got to tell you, but thank you for your efforts. Okay, don't give up.
Thank you for your public comment. Next up here, we have Keith Duncan. Keith, you should be receiving that request on your end.
Can you hear me?
We can, Keith. Please go ahead.
Great. Thank you very much. My name is Keith Duncan. I'm actually a CEO these days, having retired as a pathologist at the end of last year, and I'm involved with the Independent Practice Association. And this whole pain medication issue has really become tumultuous among our providers, in the sense that it's one thing to try to follow the guidelines, but now because of the strictness and application of these guidelines, that a number of pain management specialists have elected to get out of the area, reduce the number of patients they're seeing. So it's really leaving a number of the primary care physicians on the front line who are quite impacted. And unfortunately, I'm aware of a couple physicians in our area who have been disciplined. One has left practice, and this is really a void that I am concerned about in terms of maintaining proper coverage for the remaining patients, not just pain management. And to me, the thing that was striking, there were like three 4-letter words that kept recurring in all of the conversations. The first was pain, and that you can clearly hear in the voices of the patients today and their families. 2 was risk, and the risk is to the doctor, is they see other physicians who are being disciplined, losing their license, and basically relinquishing their practice. And then fear, and the fear is really shared by both parties. So I know the document does not really address enforcement, but I think that's almost a key issue here with the medical board and the DEA, that there should be some modification, softening of the application of this. It seems to have swung the pendulum so far that it really is putting a number of physicians at risk due to this fear of being able to prescribe and help patients. So thank you for allowing me to speak.
Thank you for your public comment. Just double checking. Don't see any additional requests at this time. Whenever I say that, we usually get a couple more though. Okay, Dr. Thorpe, I'm not seeing any additional requests. I can keep monitoring for you if you'd like.
Well, yeah, I think if you could keep the monitoring it for a couple more minutes, and I just wanted to to take this opportunity to say we really appreciate everyone's comments today. Again, my point about it's tragic about the difficulty with Dr. Bakoff, and I really don't want to. I'm not. I'm not trying to say that that's not an important issue. My concern is trying to make sure we had adequate time to discuss the need for revision to the guidelines, and so I appreciate everyone's input here today on the broader subject of chronic pain management and the difficulty with finding doctors to take care of you. That's why we've taken this approach to try to find a way to bring the pendulum back more towards the midline rather than so far to one side or the other. Actually, if you will remember, there was a period of time when opioid prescribing was extremely liberal and probably too liberal back in the early 2000s, and that was a kind of a knee-jerk reaction, and we didn't realize things were there were the problems that we were having. Now it's swung all the way to the other end of the spectrum, and we are obviously experiencing patient harm, at least in some element. There's some element of patients that are being not being adequately treated for their pain, or at least that's what it appears. So we will take these comments that have been given today, and we really do want to try to provide a better document that is helpful to both patients, not just. I mean, we are concerned about intractable chronic pain patients, but we also are concerned about the many patients that don't have that problem, and we want to make sure that they're treated safely as well. We want to make sure that doctors feel that they can prescribe opioid therapy if it's necessary, and be able to take care of very sick, chronically ill, intractable pain patients without the risk of impairing their practice ability with discipline, or if it's not needed. So we thank you very much. Any other comments, Bill, that you would like to make before we close?
Got one new first-time commenter in here, if you'd like to take that.
Oh, okay. All right. Yeah, sure.
All right. Mary Dallas. Mary should be receiving that request on your end there.
Hello.
Yeah, we can hear you, Mary. Please go ahead.
Hi. I'm Mary Dallas, and I have been in chronic pain for actually over 30 years. I've had a multitude of issues that one thing happens and then something else happens after that. But I don't want to go into that. What I do want to say is that this situation that is happening to physicians is not only criminal to the physicians, it's criminal to the patients. The situation that I'm in right now as a patient of Dr. Bakoff is absolutely practically putting a gun to my head. I was due to get my medication, as a number of other people were, with Dr. Bakoff. My brother has called umpteen medical offices, medical facilities, as have I. I've had pharmacists that I have received medications from for years that have advocated for me, and the doctors are scared. I understand that. I feel bad for the doctors. I wouldn't want to be in their shoes at this point. The criminal aspect of this goes even further. The fact that you can have drug abusers, you can have these people who take drugs and they ruin their lives. They go to a drug abuse center, they get treated carefully, coddled, given every opportunity in the world to stay clean. And when they're done with that and they get off the drugs, they're not left with pain. They aren't left with agonizing pain that they're rolling on the floor
And don't by any means think that I know for myself and a couple other pain patients that I know personally that the medication we are prescribed, even at higher doses, takes the pain away. It takes the edge off. It allows us to take care of our homes, to go get groceries, to take care of our aging parents, I am recently have become a grandmother in the last 2 years, and I want to spend time with my grandson and do things, and I can't do that. If I don't have this medication, I can't imagine what I will do. This is the second time I've been through this. I went through this in 2018 with Dr. Ernestina Saxton, and she was wonderful. She kept me and her other patients able to have some quality of life so we could participate in life. And now, because of her prescribing, and there was nothing like this going on at that time. Anyway, I just want to thank you for anything that can be done, and I really appreciate people who are doing this, and anything that can be done is greatly appreciated. Another thing, has anybody been told at USC?
Please
I went
conclude.
there and had been a previous patient. They were the ones who put me on the OxyContin, and now I went back there and they won't want to prescribe it. They want to put me on ketamine, and I'm terrified as I'm one of those people who's allergic to everything.
Thank you for your public comment. At this time, Dr. Thorpe, there's no additional requests in queue.
Okay, Bill, any closing comment that you want to make?
No, just to thank everybody again for their for their comments, for their interest, for the written comments. It's been very helpful to us, and we'll now go back and look forward to bringing the project to a conclusion early in 2023.
Okay.
Dr. Thorpe?
Yes, Carrie.
I just wanted to indicate someone asked a question about whether the second draft would be available, and it is on the board's website as part of the meeting materials for this Interested Parties meeting.
Thank you, Carrie. I appreciate your paying attention to that. Okay, well, thank you, everyone. I appreciate everyone's participation. It's been very instructive, and we're so grateful to all of our public members and our subject matter experts for all of the help. We hope to have a document that is going to be, I don't know that it'll be perfect, but it's going to be a work in progress. We don't think that this is going to be something that is going to stand, in memoriam for the next 10 years. It's going to be something that we are working on fairly consistently over the next, as the science evolves. Thanks, everyone. Thanks, Sean, for all your help in monitoring this. And for Susan and Letitia and Reggie, thanks, everyone. Have a good day. Bye-bye.